name is Dr. Sean Timothy Lordan, and I am the host of the Hooked on Health podcast. Here today with us is Dr. Brandon Smolarek, and he's a local chiropractor doing wonderful things. And Dr. Brandon, can you give us a little, background on yourself and in your practice and all that great stuff?
Sure. I'm again, like you said, the name's Dr. Brand Smolarek. I'm a chiropractor in Shrewsbury, Massachusetts. I'm originally from Michigan, but made my way out here for hockey and then college, and you know, met my wife in Boston. We ended up out here in Worcester, and you know how the story goes. I went to the University of Bridgeport College of Chiropractic, now School of Chiropractic, for my chiropractic degree, and that's where I really fell in love with the idea of blending sports science in with family medicine. And after graduating from the university, I came up here to Central Mass. I worked with a provider locally for a year, and then joined a larger group and got started on my own. So we opened up the practice in Shrewsbury in 2021 in June, and since then, after getting it rolling by myself for a year, over the summer I renovated the office. We brought on another chiropractor, and we're officially the chiropractors for the Worcester Railers and for Holy Cross Athletics.
Love to
So
hear
it's been
that.
a busy summer
It has been a busy summer for Dr. Brandon.
slash fall. Now it's fall now.
Yeah, I mean, almost winter.
Yeah, basically it's gonna
So,
snow
Brandon,
today.
give people an idea, because I feel like a lot of people don't realize how long, like what your schooling entails.
Yeah, absolutely. So I did, as customary for a lot of people who end up in health careers, I did my 4 years of undergraduate within the realms of the sciences, got a 4 year degree in biology at Suffolk University. And then from there, you go into chiropractic college, which, depending on the school you go to, is either 3.25 years or 4 years. The only difference is that a lot of schools do trimesters instead of semesters, where they go straight through the summertime, where I picked the 4 year program because I wanted the summer to have the opportunity to do internships and work in offices and see what I like. So that's where I got introduced initially to sports science, working at Tulsa Chiropractic in Boston over one of my summers. They're the chiropractors for Harvard and the Bruins and the Celtics and Patriots. So they have a pretty good grasp of how to do things with professional sports, and I'm just trying to emulate what I learned there and put my own spin on it here in Massachusetts.
Yeah, that's great.
Central Massachusetts.
Central Mass. Yeah. So we work really well together, Brandon, and I know, specifically with my Shrewsbury office, it's a great, cross referral pattern. So really my first question, and this is one, again, geared toward our listeners who are, patients, how, in your eyes, how do you see our two professions working together, and what do you think are the pros to our, the relationship between a chiropractor and a PT?
I think broad scope is that we've seen time and time again through research that multimodal care is always best for patient outcomes. So I really like having the referral network with Concierge Physical Therapy for a couple of reasons. One, I know after speaking with you and the providers that are there, everyone there knows their salt pretty well, which is great. So but in regards to chiropractic and physical therapy working together, you have two professions that are very well in the trenches with neuromusculoskeletal care, having a slightly different approach as to how to go about it. So, for instance, I take the notion of joint mobility with the mechano and nociceptive and proprioceptive input being cause of dysfunction when disrupted, causing improper muscle firing, where some physical therapists may take the opposite approach, where maybe it's more so the muscle imbalance. Now I sorry, I said imbalance. I hate using that word. The poor muscle firing. So, I don't want to put words in your mouth with how, you guys do with your things at physical therapy or at the concierge physical therapy. I know that, my conversations with a couple of your PTs there have always been, pretty on par, but it's great to have two people or two groups that have a very similar thought process of care, but slightly different approaches to achieve whatever that patient's goal is.
Yeah, and I think too, for our listeners and for patients out there, chiropractor, and you included, and I think the muscle imbalance or the, rotations and this and that, and we talk about research and, it's just the difference between even myself and some of my providers that work at Concierge, uh, like we call this like inter-rater or how we're going to relate it among ourselves. What we see is drastically different sometimes when we're looking at a human body. So if you could talk about that, that'd be awesome. Just because, I think, and kind of talking in that patient friendly language, like, we want to make sure that we fix the pain first, right? So that's, huge for us, and we address that. And then beyond that, we want to get people moving, right? And that means flexibility, really talking about getting them back to what they love to do now that they're pain free. And what does that involve? And that's, to me, it's a total body approach. And I feel like that's why we connect so well, Brandon, is because you look at things really through a similar lens. So can you
Yeah.
talk about that a little bit?
Yeah, you hit a lot of my high points there. I think first and foremost, it's what are the patient's goals that come into the office? Because if they're coming in because their back hurts and they can't, work, that's one thing. And if their other thing is, working with athletics, their goal is more, performance based. And obviously you have kind of a different treatment approach going in. But the other thing that you touched on was, even within your own office, you can have people see the same thing and have a slightly different take on it, which I think is important because working in healthcare period, but very much more so neuromusculoskeletal or musculoskeletal medicine, i.e., physical therapy, chiropractic, it's a really relative gray area. So what I might see with a sacrum that's rotating or not rotating through a hip hinge or something like that, versus you coming in and seeing maybe something slightly different is ultimately going to help the patient more because it gives them more options as to what they can do to help improve whatever it is their goals are.
Right. I mean, they don't
and,
care
and
what we see, they just want to feel better.
exactly right.
And I think that's where, you know, our communication is huge because,
Hmm.
and we can talk about this too a little bit. I know we had some questions lined up here, but the 50-year-old, sciatica patient or the 50-plus-year-old low back degenerative disc disease, has a little bit of flexion and extension pain. Like, talk to me, walk me through that, and and how you approach that, and where you see your relationship with us, as a benefit to our patients, our shared
Yeah,
patient.
and I mean, I can go through a couple instances where I did use you guys as a resource for a couple patients that they come in with whether or not it's a hot disc or a stuck SI joint or some rib dysfunction, and I give them the what I think my best approach is to care. Some people just don't respond to the way that you expect them to respond to things. So I know I had a patient who came in with a hot disc, and my goal with care was, we know that the disc is the pain generating tissue. We know that discs typically repair and extension, so let's take them through the McKenzie extension protocol, which is just certain stretches and exercises to try to get the right load into the disc to help the disc get that nutrients that it needs to help repair, and take it from there. And unfortunately, sometimes it doesn't go the way that you'd hope that it would. So I know I sent them to Dr. Marielle over at your facility, and the slightly different variation of approach with the core stability, hip mobility, as well as tuning up the muscles of the hips that need to be tuned up a little bit more, ended up resulting in better results than the load base, which I've had work for other patients in the past. So it's again the relative gray area that we live in, where you can do all the things right by the book and find that maybe that's not just going to help for this one person in front of you that day, which is why I like now having another provider in my office, because it gives you another set of eyes who can go about it a little bit different way, as well as working with the physical therapy group that we do work with to ultimately try to get the patients back on their feet and moving again.
Yeah, and I think pain medicine has a role in that too, right? And I think
Yeah.
a lot of people come to us from their primary cares or from physiatry or from orthopedics, and they may not have experience with low back pain, or they may not have been given much education about low back pain, and how important it is to come in and see us like as soon as possible if you have a bad twist, or
Yeah.
and again, I mean, and I personally have had low back pain. I've had symptoms, and it's not always a mechanism, right? It's not always a
Right.
bend and a twist and a pop. Sometimes you just, for me, I can share anecdotally that I was painting a house, and the repetitive motion of that, really set my back off for a
Hmm.
few days. And fortunately, I know what to do, and I was able to kind of self treat a little bit. But many people in my situation would have just taken ibuprofen and just, tried to, look it up on YouTube. And to
Right.
that, what would you say to that?
Well, one, pain is often not a sign of tissue damage to start. So just because something is incredibly painful doesn't mean that there's a lot of extensive damage in there that is a reason to not move. But two, the inflammatory process has its role in care because that's how our body repairs. So if you start to inhibit that inflammatory process, you're not giving your body the ultimate, the upper hand and getting back to where it needs to be. And also, I've seen some gnarly stuff on YouTube. Like, YouTube is not a filtered system of evidence-based care, and even there are a lot of good things on YouTube as well.
Mhm.
But those good things need direction, and you go on because your back hurts, and you click on things that are helpful for back pain, and you have a stuck SI joint, and this is telling you to load an extension. Like, I don't think that that's probably going to feel very good trying to do that. So the educational piece that comes with it through the physical therapy office and through the chiropractic office, I think are important as well. And that's why, when patients come into my door, and I'm sure coming into your door as well, the home exercises that they get are directed toward their care so that they can see a video of whatever it is that they need to do at home and not just be left to searching things on their own.
Yeah, and so that kind of leads me into my next question for you. So, a common diagnosis that we see, Brandon, is sciatica, right?
Hmm.
So, sciatica patient walks into your office, no matter what age. What recommendations like do you give for that? And I'm talking about, I shouldn't really just say sciatica because,
Sure.
obviously we know how misdiagnosed, piriformis syndrome or sciatica could be. But
Hmm.
let's just talk about like radicular pain. So,
Sure.
and for the audience, that means any pain that goes down your leg, that's coming from the low back. And talk to us about like, two or three, I guess pearls for patients that, they can do, or, so like kind of how you look at sciatica and how you treat sciatica.
Yeah, I mean, if we're going with true sciatic pain, my favorites are always some form of nerve mobilization. So trying to move the nerve within its canal to try to, theoretically get rid of any sort of impingement that's happening along that track. And those are simple exercises where you move your leg in a certain direction with your head incorporated into it to try to get some more mobility in that, tethered to that canal again, in theory. But as you said, with sciatic symptoms, there are a lot of misdiagnoses with piriformis syndrome as well. So it depends on what's going on. If this is a true sciatica, I start get some ice on the area to try to mitigate the pain receptor or the pain sensations that's going on. Do some form of nerve mobilization, whether or not it's modified based off of toleration, because I have seen that going into a nerve loss right away with something that's really inflamed may not feel the best. So taking things lightly, and most importantly, try to keep moving as you're going through it, because we know that pain, again, is not a sign of tissue damage. It's important to keep moving, but of course in moderation, depending on what kind of pain you're experiencing.
Yeah, and so that's where, the value of a healthcare professional comes in. And we're I know I can speak for PT that we're direct access, which means you can
Hmm.
come to us direct off the street, and I believe you guys are too, right?
That's
Chiropractic.
correct. Yeah.
So that means for the audience that, you don't have to go to your primary care before you come see us. So, even if you don't have an established relationship with our office, or, any PT's office or any chiropractor's office, you can go ahead and give them a call. And as long as they're, credentialed to your insurance, you should be good to go. Um, so that leads me into my next question. So manipulation, right?
Yes.
So, and I feel like sometimes I manipulate for sciatica, sometimes I don't. And, I don't really use the word sciatica too often because
Right.
almost like it's just an overused thing in medicine. And, we get a ton of referrals for sciatica that's really just radicular pain, or it's nerve impingement, peripheral,
Hmm.
or otherwise. And I typically treat the whole path of, the the nerve, but with different nerve glides. But if you really wanted to dial in and get specific with it, you could be more specific with your nerve glides. Um, that was a little down a tangent there, but I think talk to people about the active manipulation and the cracking, right? So
Sure.
first touch on people like self manipulating their necks and their backs, and then talk about how you do it, and is it painful for people? Is it something that people are there any contraindications? Walk us through that.
Sure. So let's kind of take it from, step one. So the whole thought process is that joints get stuck. And when joints get stuck, they can cause pain signals to happen because that's how they communicate with the body. And when pain signals start to occur, you occasionally can get muscle spasms in certain areas. So what I use is some form of manipulation, whether or not it's a manipulation or a mobilization, to try to reestablish that motion in that specific joint segment that needs it. Now, that cracking noise that you hear isn't exactly a crack that's happening, like nothing's breaking. What's actually happening is you're taking a joint that is a fluid filled sac that lives in a vacuum. So nothing gets into this area, nothing gets out of this area. So what we're doing is we're stretching that joint segment quickly to try to reestablish range of motion. Well, if you stretch a vacuum quickly and nothing's getting in, nothing's getting out while you're creating space, something has to happen in that space. So the noise that you're actually hearing is a gas bubble forming out of solution. Now, that often is associated with increased range of motion, decrease in pain, increase in awareness of that area, as well as a couple other, anecdotal things that you can find with it. So
Yeah,
that's
you
that's
got
the popping noise that you hear.
the
Um,
endogenous
sorry, go
opioid
ahead.
cascade. That's my the endogenous opioid cascade. That's my favorite overused term, probably.
Yeah,
And then
it's there are
for our
worse
listeners, it's
overused
less pain.
terms.
Yeah, yeah.
Exactly, right. Now, most often, again, not we work in a gray area, so not everyone responds the way that you'd expect. But most often, people find, especially in my office, because I'm a chiropractor, and people very much associate, chiropractors with the manipulation procedures. Is that it feels relatively nice. Most people, it is a kind of an odd motion, but the end result is usually a nice, increase in motion, decrease in pain sensation. Now, for my first timers that come in, I often don't manipulate on the if this is their first time in a chiropractic office. I'll do what's more called a mobilization, which is where you take the joint into its end range of motion and then give it a light pressure to try to stretch that softly. So it's a little less of a quick motion, but still trying to achieve the same thing, often not associated with the popping noises. So I try to meet everybody where they're at. So if someone, is their first time in, they're nervous, they're not exactly comfortable with the stuff that we're going through, that's okay. We're going to take it easy. We're going to try to get more mobility out of it. And if we gain comfort and we want to give it a try, great. I often find that it helps. But if, we're getting results with the mobilizations, and, why be more aggressive if you don't need to be?
Yeah, and I think that's really important. You touched on meeting people where they're at, right? And I think that's so important in a healthcare practitioner, and a good healthcare practitioner is just the active listening, right? And we, when you really you get skilled with your hands, you can feel when people when people
Oh
aren't
yeah.
comfortable,
Yeah.
and you're just not going to get the results. And some patients really are trying to relax, and they they just can't do it. And I'm sure that you've had your fair share of those folks. But if we can get the cavitation or the pop, the research really does show that that's you want to get that active cavitation, because that's really what's associated with the best outcomes in terms of
Mhm.
so that's great. But
Yeah, but at the same time too, though, is if you're fighting through someone who's tensing up as you're going through it, is the cavitation worth, punching through a trap that's rock solid right now because they're nervous? So,
right.
as being a chiropractor, like I do try to go for those cavitations because there are more benefits that come with it. But again, we meet people where they're at, whatever is going to be best for them at that time.
Which is great, because we never want we don't want people to feel uncomfortable, and we don't want
Mhm.
people to and again, we don't want to be fighting for, you don't want to fight for the manip. It should just happen.
That's
uh,
right.
so let's talk about other options for people for low back pain, as we kind of wrap here. I think you know one of the things, even for my providers, I always say, we work really closely with you guys. Another common question is, do I need surgery? Do I need a cortisone shot? What are my other options? So when do you refer to those specialties? And how, what are your, if I miss anything, shockwave, we do shockwave, we do
Yeah,
dry
sure.
thing. What else have you seen that works, or, gels and, I don't, I'm interested to hear what you think about all that stuff.
I
Any other
mean, I have
alternative
a
options?
my patients have really been into the rock sauce recently, which is just the capsaicin and methanol, which seems to be really enjoyable for a lot of people. But my approach as a conservative care practitioner is I always go from most conservative to least conservative. So I
Mhm.
find that and of course it depends on the patient's goals. Like if the patient's in the off season right now and they got a professional season coming up in the next couple of months, maybe we're not going to do acupuncture or dry needling for this, and maybe we'll go to something a bit more invasive just so you can start training and stuff like that. But for my weekend warrior that comes in, if I'm doing my hands-on stuff and their goals aren't being met, usually my next step is likely sending them to Sean or to Dr. Lordan at Concierge for some dry needling or whatever you deem necessary. I often find that that's a little bit more of an aggressive thing of reinciting the inflammatory response, which is what we're trying to do in the office. If that's not working, I try to push patients more towards PRP, or what's known as plasma-rich protein, which is a next invasive procedure, but less invasive than a corticosteroid, where it's not as much of a degenerative process. However, there's not a lot of research for it yet because it is kind of a newer modality. So it's not something that's going to be, the silver bullet that people are looking for. So you give that with a decent amount of knowledge behind it too. So if that from there they're not seeing the results, that's typically when I'm starting to talk with my pain management specialists about maybe doing some form of corticosteroid. And if that's not working, we talk about, depending on what they're coming in for, if we're going in for, some sort of operation that happens. But the operations are usually last line defense. They're not something that you want to start with because they don't have good outcomes when you start with an invasive procedure. They have better outcomes if you try the conservative models and then those don't work. That's usually when you find that your operations are your best choice.
Yeah, I mean, I think that's great advice for our audience, and I think, and this is, we may be, we have to say that, we may be a little biased because we are,
A little bit.
conservative care
Sure.
providers, but there is a lot of research that, let's just talk about laminectomies. So for the audience, a laminectomy is where they just kind of, create more space, right? So if you have stenosis, bone on bone, so to speak, arthritis in your back, the doctors will go in and create more space for your bones to move, right? And the research shows that at 5 years, after a laminectomy or just having conservative care PT, the outcomes are the same in terms of pain levels. So, really, what I suggest is to go get that surgical opinion. I think that's important. If we've hit a wall, it's been 6 months or a year, and you've seen Brandon, you've seen, our physiatry, our pain management partners, and you've hit a wall and you're still having those symptoms or foot drop or something neurological, go for it, go talk to the surgeon, but that's always sort of a last step for me, personally, and really, at our practice, because I look at that as a loss, as as a conservative care provider. And the same thing for us. So, we do acupuncture. We try to stimulate an inflammatory response to try to get people out of the chronic phase of healing, and bring some blood flow and angiogenesis, or, blood flow to the area. We've also got shockwave at Concierge. I've got to use it on you at some point, so you know what it feels like. I don't know. Have you ever had it done?
I had it done before. My soleus as just at a convention, and the guy's like, "Hey, you want to try this out?" And he threw it on my calf real quick, and I was like, "That hurt."
Was it
It
focus
hurt
or
because I
radial?
was a. Say again. I'm sorry.
Was it a focus machine or a radial machine?
It was a focus machine,
Yeah.
and it hurt because I was nervous for it. And I think that even if he put it on its lowest setting and breathed on me, I probably still would have said it hurt. So I think that one's more on me. But I am interested in trying the shockwave. Cold laser is also a good one. Warm laser is also a good one as well. I do actually have a disagreement with you there, though, Sean. And I don't know if this happens very often, but I don't look at it as a loss if the patient comes into our doors we give them our best efforts over the course of 6 months to a year,
Yeah.
and they don't achieve their goals. I think that we can put our hat down at the end of the day and say, I gave you our best. The likelihood of the operation helping you now is a lot greater than what it was when you first started with me. So I think that this is now your best, your best approach going forward. And ultimately you're giving that patient the track they need. You saw them through the care, you helped coordinated it, you gave them everything they needed to get better, and here we are. This is the next step.
Yeah, and I think that's where, and I wouldn't say that it happens rarely, because it does happen, right?
Sure.
So in some
Had it
cases,
happen this week, actually.
and I maybe it's not the word loss, I think maybe for me it's sort of like, oh, like, and I feel like as a, and again, as a conservative care practitioner, you always look back and say, hey, could I have done anything to help manage that plan
Yeah.
differently? And I think those are the moments where, of course, like, is there anything I probably could have done differently? Probably not. Was there maybe something that they did, or they had a, maybe there's modifiable risk factors like smoking and
Sure.
drinking, and,
Yeah.
even age and, and lifestyle, like, lifestyle habits,
Hmm.
nutrition, things like this. They all play into, you know, um, they're all concomitant with low back pain, or they play into, how low back pain can potentially affect your life, and then we don't even have time to talk about depression, and, how that's really, rampant with low back pain too, but,
Right. Yeah.
and how that can affect outcomes. But I think, I wouldn't, I think, and that's a great point, Brandon, is, I guess I don't really see it as a loss. I see it as an opportunity to reflect on how, potentially, what could we have done differently to maybe not go down the surgical route? But to your exact point, you're not going to win them all, right?
Yep.
You're not going to fix everybody. And I think that's where, that's why I, that's why I do this. That's why I love what I do. And that's why I love,
Hmm.
being a PT, is that I do feel as though, um, I just, we do our best to try to fix everybody. We're healers,
Yeah.
that's our job at heart. And, that's why finding these, partnerships with PT and chiropractic partnership, it needs to happen more often. And I feel like sometimes, um, well, actually, I feel like I've always had great relationships with chiropractors in my area, but, going through school, they always, at Northeastern, they was, oh, well, the chiropractor's this, or the, massage therapist that, or, and people, back in the 80s and 90s had their different, voices on it. And I think that if we can come together and just put the patient first and offer a great product between the two of us, there's no like there's no need to compete for, for people or for patients. I think that's a little bit.
Didn't low back pain get the most common cause of disability in the United States this past year? Yeah,
Mhm.
I don't think competition for patients is a problem. The patients are very much there.
Yeah.
Yeah, but one thing that I love about your facility, and I hope that you see in our facility, is that when you walk through the door, you're going to get the best effort, no matter who you are, what you're dealing with, all that stuff. And that's why I continue to send patients your way, because I know that's going to happen.
Yeah. And
That's what you can
likewise,
do at the end of the day.
yeah, likewise with you guys. And, and a lot of times I think, just that extra attention to, and to use your words again, to meeting people where they are, to listening and really being, you know, um, just really dialing into what their needs are that day.
Hmm.
I think that that's really, the psychological component of it is huge. A
Yeah.
lot of people have other things happening in their lives, and as providers, by nature we're busy, and I think
Right.
taking that extra time, which, you guys do at your office, Brandon, is huge, to just, listen and just be present with people is just,
It's
that's
why
half
we
the
spend
battle.
more than 5 minutes with our patients. It's why we do a half-hour visits with our patients.
Yeah, I
Patients.
mean, that's, and that's, for the audience, that's unheard of, right? That doesn't exist in the chiropractic world today. And, this isn't just a local audience either, Brandon. Like, these are people, there's people from all over listening to this. But if you're ever in the area, you got to seek out Dr. Brandon. He's going to practice in Shrewsbury, Massachusetts. And um, any other parting advice you'd like to give our audience today, Brandon?
Ah, move more and see Dr. Sean when you need him.
And I would say move more and see Dr. Brandon.
Yeah.
Dr. Brandon, thanks so much for coming on today, and really appreciate your time. And I think one thing that I learned today is, that, you know, and I want the audience to take from this is that, you really want to choose your healthcare team wisely. And it's important to know that you can go directly to your local PT or your local chiropractor, and and ask them questions. Ask them who they think that you should be seeing with them, right? So whether that's nutrition, whether that's another PCP or a pain management person they like, ask them who else they should be seeing, and form your own team of doctors. I think that's really important.
I think it's a great piece of advice.
And well, with that, I will say thank you and really appreciate your time, Dr. Brandon.
It was a pleasure to be on. Thank you for having me. You know where to find me if you need anything, and I look forward to catching up with you soon.
Awesome. Thank you so much.